I've been the acting medical director for about a year and a half at the Poison Center, and we'll be turning that over to focus a little bit more on addiction. Namely, we hired somebody. And I am also part of the core teaching faculty in emergency medicine at UNM. And I have several other little roles and things, but I think drugs of abuse are kind of my niche in medicine. As I go through this, if Julie or Rachel could help me with a little bit of timing of things, because I don't see a slide number and know how many slides I have. I just want to make sure we get time for Laura's case, and I'm excited to hear that. So
Sounds good.
The objectives of the talk is talk about basically 3 FDA-approved medications for opioid use disorder, and to be able to choose between the two, and to have some comfort level on assistance on initiating and doing that. And so my first takes home, and if you go home with nothing but this, I would be satisfied. And there is no one drug or one treatment that works for everybody. I have people who have failed buprenorphine, been successful on methadone, and vice versa. I've got one patient who's failed both methadone, buprenorphine therapy, and naltrexone's working great for him. And so it's all a matter of making sure that we work with our patient. And I think that's the most fundamental and important thing, is that we have options as well. So one of the things is detox alone does not work. So in 1970, when Richard Nixon and the United States government declared war on drugs, part of that was, how do we start treating addiction? And one of those ideas was that we would use methadone to detox people. By 1973, the US government, and there was such an outcry because it was just ridiculous on just, hey, titrating people down, that we needed a new change in federal legislation for that. As the years would go by, and when the Data 2000 Act came about 30 years later, again, we anticipate people are going to be on MOUD for as long as they feel that it benefits the patient. And I can tell you from anecdotal experience, we're finishing an NIH-sponsored clinical trial of looking at people who are stable on MOUD and trying to titrate them down. And it's amazing at how many patients are really gung-ho about it. And then as soon as they start coming down on the meds and some of the cravings or ability to function is different, they're like, yeah, maybe I want to pause. So we're going to go through some of the discussion of what I just said into a little more depth. A drug and a detox free model. Again, my apologies, I didn't know I was presenting today and preparing the slides. So I think we in New Mexico have lost several inpatient stay beds, but a lot of those beds were related to where they were just detoxing people. People were very miserable. And so I think part of that historically, in us going forward into as we look forward to 2024, is a lot of our patients are fearful of wanting of inpatient here far more than any other place that I've worked. And I think a lot of them had that feeling that they're going to be absolutely miserable going through the detox. And there's several reasons that it doesn't work. Number one, patients are miserable. Number two, when it doesn't do anything neuropharmacologically to satisfy the cravings and the activity that's happening. And then 3 is when people get out of rehab, especially absence-based rehabs, basically is the highest risk factor of anything that we do in addiction medicine, with the highest being incarceration, release from incarceration. Because they lose their tolerance, and then when they relapse, they can overdose. This is a series of a variety of different studies that have been done over the years, and up to this date within the published literature, all the deaths go out to be a year. or up to a year, and they consistently show that when we withdraw MOUD early or within that time, we start really seeing what we're in the green graph or the green line, where the number starts falling off fairly precipitously. Whereas if we keep somebody on buprenorphine in this case, sure, there are some that are not in treatment, but the majority are. And in addiction medicine, just like going to the gym when you're trying to get in shape, like half the battle is just showing up and going through the options. You know, we do pretty good in January and showing up to the gym, but then February rolls around. I could be a little optimistic sometimes making February, but you know what I mean? Then the weight starts and everything starts coming back and the diet changes. So as far as roles of medication, I think in my version of the talk, and we all get to have our own little bit version of slides, the medical outcomes, I challenge you to any other treatment intervention for any other disease has as broad base of outcomes as MOUD does. In this case, we're decreasing heroin activity, decreasing HIV 4 times, increasing employment, which also, I don't know why we don't have the caveat increasing contribution to states and federal taxes, decrease criminal activity, and a lot of this is incarceration. I know use of heroin is illegal, but when you look at the studies, it's not just that they're using heroin, it's actually the criminal activities that are less likely to break into Julie's car or whatever else they're doing for drug money. And thank you for letting me use you as an example, Julie. And then less risky behavior, better child support payment. We have improved birth outcomes. Mortality rate is highlighted here. I don't know if in this slide set exactly how we set up the mortality, but we're looking at about a 70% survival rate. Again, there's not a lot of things in medicine outside of maybe insulin for insulin dependent or juvenile diabetes that has a 70% survival rate. That we have. I put a lot of time into thinking about this, and I think I have a second one that I thought of here recently as a toxicologist. So if anybody has other ideas, feel free to drop something in the chat for discussion. Decrease of maintenance therapy. Again, we're really stabilizing people, being a better parent, being a better husband or wife, being a better contributing to society as well, and never mind just a better mental health and happier point of view for the patient is pretty big. This is just looking at crime, and I'm not sure I'm familiar with the study, so I'm going to talk about a study that I did here with New Mexico, where we looked at people who had an overdose fatality versus age-matched controls who did not have overdose, and we looked at their criminal activities, and is basically property crime, of course, use, but even domestic violence. All those crimes in the state of New Mexico were significantly lower in people who in the age match controls. In other words, people who are using drugs at higher risk. So this is more of Dr. Bott's thoughts, and Dr. Bott has a lot of thoughts, it would appear. I'll just take a moment for you guys to read that I'll highlight I'll highlight a couple. Yeah, and I think a lot of this is resummarization of what we've already talked about in maintenance and preventing relapse and stabilizing people's lives. So as far as FDA-approved medication, there are 3. They're methadone, buprenorphine, and naltrexone. Starting with methadone, it is a Schedule II drug. Some of the nuances here, I think the Schedule II basically means that unless you're in a federally methadone clinic, or OTP as we in the industry call it, opioid treatment program. Methadone for opioid use disorder is unfortunately not available to you. However, it doesn't mean that the patients who you think might benefit would be ones to refer out. I also anticipate here over the next coming years, especially for the state of New Mexico, that there continues to be a lot of discussion on how do we get methadone to the 5 or 6 corners of New Mexico, depending on how you want to count, because of our ruralness. We've got cities like Pittsburgh that have mobile units, but that dispense methadone. But for us to put a van and mobily dispense to, I don't know, Lordsburg and Cuba, we're never going to be able to make that swing in one day. As far as methadone goes, pharmacologically, it's a full mu agonist, and this will be in contrast to buprenorphine, which is a partial agonist, and naltrexone, which is an antagonist, and both those have pharmacologic importance. It has a bit of a weaker affinity for the mu receptor in comparison, and so your take home from there is naloxone works really well in it. Also, if we give buprenorphine with methadone, we're knock the methadone off the receptors, and there's a good risk of inducing opioid withdrawal for patients. And who's the appropriate patient? So generally, they need to be 18 years of age and older. There are ways under the age of 18 that we can get patients onto methadone, but those are generally fairly complex. And I will defer to Dr. Plum on what treatment sites in the state are currently giving methadone under the age of 18. Thanks for letting me put you on the spot, because I know the Peak does it down in Cruces, but I don't know of very many that do.
I sure wish I knew that off the top of my head, but I think I'd have to look that up to be sure.
All right. Well, thank you for making my weak mind not feel so weak. I think that some barriers is there's a lot of stigma that it goes with the methadone clinic out there, and the location of the clinic is I think probably the most important thing for selecting for patients, because they need to go there in the early stages, like every time. And I think sometimes the having to go every day can be very plus or minus. The plus is, especially people just coming off of the streets, it's might be their only positive interaction in a day. People who are on the streets don't have an Evelyn Plum who, when you don't know the answer, has your back. And just having somebody, and our security guy at ASAP, his name is Phil, and he's great, and we'll greet everybody, say hi to them, and we'll be able to have a little chit chat with them. And I think that is really important to understanding that not everybody is out to stab you in the back and steal your money or your drugs. At the same time, other people coming off the streets is developing that routine in life, and knowing that if you don't get into the clinic, you're going to be miserable, forces people to get up out of bed. Again, sometimes the addiction clinic's kind of like the gym. Once you get to the gym, and even if your intent was to use the hot tub and the sauna, you spend a little bit of time on the rowing machine just because it was there, and you start talking to somebody, or a little time on the treadmill. And so again, we just want to keep moving things along.
Dr. Rourke, do you mind if I chime in there real quickly?
Absolutely.
This is just so relevant. Last week, I was doing the CSW Echo, and we were talking about trauma-informed care in exactly the same context, talking about the social architecture of the clinic and how we can welcome people in. Thinking of places like the Mountain Center, these low barrier clinics, there are so many factors that go into what makes a patient feel welcome and feel at home when they come into a clinic. And I think that's something that when I was early on in this role, I really underestimated, but over time, it's one of the things that patients mention the most. It's about the faces that they're used to seeing at the front door. It's the atmosphere of the clinic. I think we really kind of underestimate these so-called soft factors of, what gets people through the door. And like you're saying, Dr. Warwick, it can be really hard to convince yourself to get out of bed and get there. But if they know they're going to get a warm welcome, it makes all the difference for a lot of folks. Thanks for letting me.
Yeah, thanks for reinforcing that, Evelyn. I think that's such an important point. That's because, if somebody's dying of cancer, we tend to really be compassionate with them toward the end of care. If you're compassionate with our addiction people early, you retain them better. And then by the time they're a pro at this and they're in recovery, they just want to be in and they're out and they've got busy things to do. It's kind of the opposite. And I actually enjoy it. So buprenorphine is a partial agonist. Some of this stuff with the Data 2000 Act has made it possible. I want to avoid some of the minutia because the laws have changed here. And I don't know if this is all updated. So like the X waiver information is no longer relevant. What any prescribing physician of any controlled substance to renew your DEA, you do need 8 hours of CME. And the good news is this counts as one of your 8 hours. So we hope to see you for the next 7 or more. And that's all the more I wanted to spend on that time. So we have the tablets, we have the films, and we have an injectable. We actually now have 2 injectable products that are FDA approved, with the second one is coming on the market here in September. I haven't seen the pricing information for the new one, but I'm really hoping that the price comes down. As we discussed last week, we have some issues with the REMS and trying to make buprenorphine or the injectable available across the state. And I think more work will be done on that. I think office-based buprenorphine, this is great. It's easy. You can do it in a primary care office. You could do it in an endocrinologist's office. I'm not sure why, but well, I know why you would do it in an endocrinologist's office, because it's the need's that high. And all you need is the DEA license. Also, as we walk through this, the New Mexico Poison Center, and Rachel, if you want to put our phone number in here, we're kind of unique in poison centers of the 55 in the country, in that we also cover addiction related issues. So it's myself, and then we've got two other board certified addiction physicians that take call for the poison center. So 24/7, 365, and that's a free service for you. And I think a lot of that is, how do we start initiating people on buprenorphine? I'm thinking about it. I've never done it, but I've got that right patient. We want to be there to be able to walk you through it. And if you're a seasoned pro, like the Mound Center is, and you just need some help with OB or some really complex case, and just to bounce the idea off of somebody, we're there too. As far as I'm just going to go faster through these slides because I think this is just data analysis, and seems a little bit older. Naltrexone. So naltrexone is the opposite of all of this, is a complete antagonist. You got to be careful on the induction. I actually prefer, I want them completely off opioids. It was supported by history. Several providers want a urine drug screen that's negative. In the fentanyl era and the lack of fentanyl testing that provided from Tricor and other labs in the state, I don't know what a negative opioid screen really means anymore. But I'll also do a test dose of nasal naloxone to see if they have any precipitated withdrawal. Because when naltrexone-induced opioid withdrawal, it's severe, it's very unpleasant for the patient, and it's going to last for 48, 72 hours. So I really don't want to put them on it. The challenge with naltrexone when you introduce it is getting people through their first month for sure, and get them onto that second or third shot. Individual pills, I will try a pill initially, usually like for a week or so, make sure they tolerate it before giving a month-long injection. But I really try hard to get all my patients on a month-long injection, just because the long-term data suggests that it's more efficacious or better retention into treatment. Basically, the patients aren't choosing the days that are going to relapse. So as far as how do we choose, a lot of this I just run by the patients and see what the patient is thinking, is as far as what they wish to do. Honestly, if the patient is most patients have tried buprenorphine, methadone before when they come to me, and I'll base it on some of their previous experience. If they're completely clueless, my personal preference is start with buprenorphine, just because the transition from buprenorphine to methadone is easy. And most patients just really struggle that first month on naltrexone, the cravings and everything. So as far as how long do we stay in treatment, I know we're running to the end, and I think we covered that. And so with that, I just want any questions, and I most importantly am interested in Laura's case.